So she's a 72 years old female who presented with history of muscle weakness for 6 months. Then 3 months prior to admission, patient had started developing difficulty in breathing.
Yeah, thank you very much, Seba. This is the a good category because you're saying already that this elderly woman is presenting with muscle weakness. So that I don't miss anything, I'll say patient has weakness. So in the HPI, maybe should come up what exactly do we mean? But when we say weakness, is it means a case like this, I believe, is a true neurological weakness and not a stain that specifically went into muscle weakness. But to discuss weakness in general, and I believe the difficult breathing that follows 3 months after the weakness started is also related to the weakness because to breathe, you also need neurological input plus the muscle to respiration muscles to act on it so that you can breathe. But if you say true neurological weakness, you realize you are talking about a motor deficiency of a muscle. And the motor of the spinal cord, from the spinal cord to the peripheral nerves, intermuscular junction, and then the muscle. So if this is true muscle and not the others above it, different differential diagnosis will apply. So I think I should stop there and listen for the HPI and then dissect what I will be thinking, whether this is muscle or not, depending on how it will be. Back to you, Seba.
So this weakness was of gradual onset, progressive with time. So initially, it involved both upper limb and lower limbs. So the patient reported that she had difficulties in standing from sitting position or from squatting position and even climbing stairs. So she could not hold heavy objects as she used to do previously. And 2 months later, she could not walk on her own. She needed support to walk. So she reports that these symptoms did not worsen with repeated activity. However, she reports that she was having difficulties in feeding herself, holding a cup of tea, tying her bottoms of the shirt, and also obtaining things above the level of the head. So the difficulty in breathing, which started 3 months prior to admission, was gradually progressive, worsening with time. So initially it was more an exhaustion, but later on, patient reports that it became symptomatic even if she was working at her home place. So at some point, she reports that she could stop and sit to catch her breath. There is history of cough that was dry in nature, on and off, that was reported more during the night. Patient reports to have history of wheezing 1 week before admission. She reports all of this to be accompanied by easy fatigability and generalized body malaise. Yes, that was the HPI, Dr. Joseph.
Yeah, thank you very much. So it makes a broader sense. Now, uh, from this history, we completely now know that this is not just a asthenia that someone says, I feel, doctor, I feel weak, but this is true neurological weakness that the patient has. And so we are dealing with a case of neurology today. And when you see a case of neurology, before you do anything, you shouldn't be scared. You pause and say, you need to have just two things. And then at the end of the day, you can maybe get the diagnosis right or come close to get the diagnosis right or even know what test to do that can give you the diagnosis. And these one, you have to say where is the disease? Like localization, fancy name is called localization. But it's to say where the disease is, which we do also in other aspect of systems, like patient with abdominal pain, you palpate, you say where the disease is, you say epigastric region, for example. So in neuro also that's the case. And then the other one is the duration, like what's the tempo of the disease? Is it acute? Is it subacute? Is it a chronic disease? A patient who says, I was walking and all of a sudden my limbs are out, I couldn't do anything. Hyperacute is the differential diagnosis will be different from a patient who says, like this one, that I was walking and then slowly I feel weakness. It's over months and feels to be progressive. So let's start with localizing this disease. And as I've talked before, localization is just those places. You have disease which sits in the brain, spinal cord, peripheral neurons, intermuscular junction, and then muscles. What are the chances of this disease sitting in the brain? Zero, because what disease will sit in the brain and cause weakness in the upper limbs and lower limbs, which is progressive slowly over 6 months. Theoretically, it's possible if you have something sitting in between hemispheres of the brain, compressing the motor area on the left and the motor area on the right. Oh, that's theoretical, but I think the chances are zero here. You say again, is this disease of the spinal cord? So disease of the spinal cord, if this is a disease of spinal cord, it will be the cervical spinal cord, because once you go below the cervical spinal cord, you can't involve the upper limbs. So, and two things more very important that people with disease of the cord will have. They will have blood and bowel symptoms. They will say they can't hold their urine, or they can't push down to have a bowel movement, which is not the case here. And then intermuscular junction, sorry, before that, neurons. So if you have neurons, have motor weakness, then you have sensory. So if the disease will affect both of them, you will expect to have sensory symptoms, which are not here in this case that Seba is presenting. But you can say, yeah, you have purely motor disease, like motor neuron diseases. Can they be like this? And the answer is maybe, but the picture doesn't look like this. Those diseases will start affecting a limb first and then another one. But they are possible. So we put that aside. Maybe it's a pure motor neuron disease, this disease. And the next is the intermuscular junction. And intermuscular junction, one aspect of it is a fatigable weakness. That's why Seba asked this patient if weakness occurs on repeated activity, and that's not the case. So we say this is not a fatigable weakness, so this is not maybe intermuscular junction. And then the final is the muscle that Seba gave us in the chief complaint, so that we cannot go through all this hassle of trying to find out. And then I agree with the chief complaint, that's muscle weakness, because many aspects of this disease falls into that. So these diseases of the muscle will lack, for example, the peripheral neuronal symptoms. So there are none here that you're seeing. Patient is not saying anything concerning maybe numbness, paresthesia, and some sort of those things. But again, if you look at it, you realize this started as a proximal muscle disease. Which muscle disease starts like this? Proximal muscle meaning like so standing and squatting. To stand, you have like you hold your chair and then you stand. You have to use your proximal muscles of the lower limbs, plus maybe reaching above or feeding yourself. You have to hold a cup and then take it up. So your proximal muscles of the upper limbs are involved. So I think this is a true muscle disease, which is proximal muscular weakness. Now, after saying that, I'll come to what are the diagnoses that sits under there. But this patient has another thing, which is a DIB. So is there a chance, as I said initially, maybe this DIB is involved with the weakness? Is this patient also have muscle weakness that causes this SOB? And then if you say that, you will miss something, because if that's the case, why would the patient have a cough? A cough, it means the respiratory system is irritated in some way. That's why this patient is having a cough. If you ever seen a patient maybe with a GBS, in which you have weakness which ascends involving the muscles of respiration, this patient, they will have at the end, because they have been admitted somewhere, they don't have the financial method to have the treatment, and you can look at them and see what the disease is eating them up. And what you see is you admit them with weakness, it ascends. At one point, they start having a DIB. They don't have a cough. So that's the case. So I think DIB have to stand on its own in these patients, and not to say they have also weakness of the muscle, but they have a disease of the respiratory system. And respiratory system plus any other thing that can cause DIB. And when we have discussed here before, if you have DIB, 90% of the cause will come either from the lungs or from the cardiac. So one of these. But if you also have a cough, more likely to be coming from the lungs rather than from the heart. So what are the things that maybe can cause proximal muscle weakness? And to go down there, I think some that you all know, you've heard or seen. One to start with will be polymyositis, for example. And then you have other inflammatory myopathies like dermatomyositis, inclusion body myositis, medications-induced myositis, and others. And then if now DIB stands on its own, what are the things that can also present with the DIB and then have myopathies? The easiest answer is a patient with primary pathology of the lung. For example, they have a cancer of the lung, and then they are presenting with myopathy as a paraneoplastic syndrome. That's one. But number two, you can have autoimmune diseases of the lungs that can also present with the myopathies. That's also true. So you already know now where we'll be going. Like no one will do MRI of the brain in this patient. So we'll be focused on the pathology of the chest, then the pathology of the muscles, to come up with the common things that can affect them both. So Seba, I think we should proceed from there.
Thank you, Dr. Joseph. So coming to the review of other system, it was unremarkable. So in the past medical history, this is the patient who has been diagnosed to have bronchial asthma for more than 20 years. And the last attack was about 3 months ago. And she reports to be on formoterol-based regimen. She has also been diagnosed to have hypertension almost for 1 year now. And she's on losartan, 50 milligram OD. She reports to attend a monthly clinic regularly. She has a previous diagnosis of pulmonary embolism, and she was kept on rivaroxaban for 12 months. But as of 3 months ago, she reported worsening of difficulty in breathing, despite using her rivaroxaban and antiasthmatic. And prior to admission, she reports to have one episode of a severe attack, which was managed at home without any admission. So about 3 weeks prior to admission, patient had an episode which was accompanied by difficulty in breathing. She reports to have wheezing, then lower limb weakness, which necessitated the admission, which we are currently discussing now. Maybe anything on the past medical history, Dr. Joseph?
Yeah, a few things that are very important because someone says they have been diagnosed with asthma, and then the question is, how was it diagnosed? My experience here, and I have done it, diagnosed this patient, said asthma. I would ask, at what age specific that you were diagnosed with asthma? The true answer that I take this can be true asthma is a childhood asthma. Someone can be diagnosed as an adult um, with asthma, but I put a question mark when I see that, and especially when I see things like this also coming up, because someone comes in the clinic and they have wheezes, they have dyspnea. You give them some maybe something, an inhaler, and it's fine. You give steroid, they feel fine. You say it's asthma, but maybe it is not. You haven't ruled out other diseases that can also present with the same picture. So I put a big question mark on that diagnosis of asthma. So I say maybe this is another lung disease which presents with on and off dyspneas respond to these inhalers. A diagnosis of PE is very important, and now if you have you can be diagnosed PE and there's nothing nothing has caused it, but we usually try to find out if there is a cause that is there. But no matter what, if you don't see any cause, we just give you rivaroxaban. But the patient who is also on rivaroxaban and coming in with SOB, you can try to be reassured and say PE is out of the way because they are already on rivaroxaban. And if you do that, you'll be lost because there are other diseases. There are other diseases which causes the pulmonary embolism, and they don't respond to rivaroxaban. A famous example is antiphospholipid syndrome, for example. The treatment of antiphospholipid syndrome is, I think, warfarin rather than rivaroxaban. And one prayer is that you see a patient who is clotting through rivaroxaban, just say this is APLS unless proven otherwise, because they shouldn't, unless they don't take their rivaroxaban. But if they are, and you see the PTT is okay, is in the level, you say they shouldn't get a PE. So I can say, okay, maybe they have another PE. I'm not completely ruling it out. So I'm keeping it there. And if it's there, I'll think on the side of APLS. Yeah, so still thinking of what can be worsening this DIB. So there are other things. For example, you can have, I can say, interstitial lung disease. Interstitial lung disease, this a big category of diseases. A lot of diseases are falling into that category. It's not just a single disease. And some of them can be autoimmune. They can predispose you into getting autoimmune myopathies, vasculitis, which causes also pulmonary embolism. So I'm not delving into that unless I'm getting other data, because to be maybe take a lot of our time, and I'll be going astray if I do that. So back to you, Saber.
Thank you, Dr. Joseph. I think that was an excellent discussion. So, coming to the part of physical exam parts, patient was fully conscious and febrile. She was not pale, not jaundiced, not cyanosed, not dehydrated. She had no any angular stomatitis or oral thrush. There was no any aphthous ulcers. There was no petechios or ecchymosis. There was no Gottron papules or show sign. There was no any Raynaud phenomenon or any palpable peripheral lymph nodes. No any other stigmatas for chronic liver or kidney disease. She was tachypnic, around 24 breath cycles per minute, saturating 80% on room air. With a supplemental oxygen, which was non-rebreather mask, she was able to maintain an adequate oxygen saturation of about 98%. She was febrile. The blood pressure was about 138/82. Pulse rate was 96. BMI was 26.6, and RBG was 5.4. So per abdomen was fairly normal. Respiratory system, apart from tachypnic and mild to moderate respiratory distress, there was no any other significant finding. The musculoskeletal and the cardiovascular system were unremarkable. Coming to the nervous system, higher centers were fairly normal. The cranial nerves had normal findings. This was the motor examination. I hope, Dr. Joseph, you can see it from your side.
Yeah, I can see it.
So, and this was a motor examination in the lower limbs. Yes. Any comments, Dr. Joseph?
Oh, I'm muted. Okay, I'm muted. So, yeah. So, can you hear me?
Oh, yes, yeah, I can hear. Oh, you'd want to start from the general exam?
Yeah.
Okay.
Okay, very nice examination, and it proves what we've already discussed on the history. So let's start with these vital signs. Vital signs are vital. That's why we're discussing them, and then I'll include that with the respiratory system exam. So this patient is tachypnea, starting 80s, and I believe, Seba, it is clear auscultation, right?
Yes, Dr. Joseph?
Clear auscultation. Yeah, auscultation, nothing.
Yes, yes.
Yeah, that's very important. So the conclusion from this is the respiratory exam is that the respiratory system of the patient is fading. That's it. It's fading. So what is important? Tachypnea or desaturation? Desaturation is more important than tachypnea. If you run, you can have tachypnea, you won't have desaturation. Desaturation, when you see it's an emergency, you have to make sure the patient is on oxygen, they're saturating normal, and then you pause and find out what's causing the desaturation. So if you see a patient who is desaturating to arrive at diagnosis, after you've said there is nothing blocking the airway, for example, if they have asthma, you treat the asthma. One is that there can be something filling in their lungs. These things, like for them, you can have water in there. I'm talking about pulmonary edema. Or you can have a pus. I'm talking about an inflammatory process like a pneumonia, or you can have blood, for example, things like capillaritis or diffuse alveolar hemorrhage. Yeah, those that can infiltrate the lungs and you can have desaturation. If that's not the case, for example, how do you know that something is infiltrating the lungs? You put your stethoscope, you listen, you say there is nothing, but you don't say there is nothing by stethoscope. If you hear as crackles, for example, say there is something infiltrating the lung causing desaturation. But if there is, you don't hear anything, you say maybe there's something, but my stethoscope has a low sensitivity, I'm not hearing, I'll do imaging. Chest X-ray CT, they will tell you if there is something or nothing. So if there is nothing that is infiltrating the lung, there are other causes that can cause desaturation. For example, you can have blocked vessels. PE still stands there. Especially important in a patient who is desaturating with a clear auscultation. Think of a PE. That's what I do for myself. I see patient desaturation, put a clear. My threshold for getting a CTPA becomes very, very low. So we'll go there. And then others are rare. For example, you have an abnormal hemoglobin, or you have a shunt, for example. So those are rare things. But importantly, anything infiltrating, pulmonary embolism, you sit there first. If you don't see any of them, then we can go to those rare ones. And then the CNS, we are lucky. It's very simple. The CNS is very simple in this case because there are no many things to discuss. There is only one thing. This patient has proximal muscle weakness, period. Nothing else. So this is a muscle disease. What we are seeing here, the distal muscles, they're 5 out of 5. and only the proximal muscles, the flexor on the elbows or bilaterally. So this is a purely muscular disease. Let me see if I can make any progress now for this case, because now I know exactly that this patient has primarily muscle disorder, and they have another disease in the lung. What can I think of? So I said, one, this can be a single disease which affect both of these things, or it can be a disease of the lung, for example, a tumor of the lung. So what a tumor of the lung can do itself maybe cannot cause desaturation with a clear auscultation, but a tumor of the lung is a hypercoagulable state. It can predispose you, you can get a PE, and then on the other hand, it can cause paraneoplastic syndrome and cause polymyositis. So that's one. If I'm thinking of another one now, APLS and muscles, less likely. APLS can also maybe give you a PE, and you can have still a PE even if you are on rivaroxaban. But APLS with muscles, I think that connection, I don't have it. But again, we're just saying muscle disease, and I mentioned some there, but exactly what is this muscle disease that we are seeing here? One neurologist that I read his book says he doesn't, because if you see a patient, we say, okay, no problem, we take this patient to EMG, and then they will tell us what is it, or muscle biopsy. But he says maybe not to rush, because you can have a differential diagnosis even before going there. So for example, in this patient, I mentioned dermatomyositis, polymyositis, but this patient doesn't have a rash, and maybe dermatomyositis less likely. So we have polymyositis that is also possible here. Including body myositis. Including body myositis usually also has an aspect of a peripheral weakness, not just purely proximal weakness that we see in polymyositis. And then it's also say that there is asymmetry, some asymmetry, not like this. This is purely symmetrical. Meds, I talked about meds, especially statins, can also cause drug-induced myopathy. This patient is not on any that we see. So we'll go around there, and then you have other rare diseases like genetic disorders that can also affect both of these things. So if we delve into the world of genetic disorders, we'll tend to maybe go away from the lungs and say, what if it's a cardiac disease? And you have dystrophies that affect both the cardiac and the muscles. But I will do that if I already know that the lungs of this guy are completely clear. There's no PE. The lung parenchyma is okay. So back to you, Seba.
Thank you, Dr. Joseph. I have to admit that is an excellent clinical diagnosis approach. So coming to the sensory, all the modalities of sensory functions were normal. Coordination was normal, but gait was not assessed due to weakness. Coming to the part of investigation, this was the complete blood count of our patient. Maybe anything you want to comment on, Dr. Joseph?
Do we have any other lab so that we do all of the atoms?
Okay. These were the inflammatory markers. Several markers of muscle injuries were done. The creatine kinase, AST, ALT, troponin, and LDH. Autoimmune markers were done. And also complement levels were done to this patient. Then we also went ahead and performed the renal function test and serum electrolytes. Serologies were also done. Tumor markers were also done to our patient. Thyroid function test. Liver function test. The enzymes together with other liver synthetic functions were also done. This was the lipid profile. A transthoracic echocardiography was also done. Maybe we can comment on the lab before going to the image part.
Okay. Thank you. Yeah, so I think this CBC, except that very, I think in Africans, this 12.19, oh, this is normal for me. I'll not do anything with this. Let's see the other one. Yeah, so inflammatory markers being elevated, the ESR and the CRP, they're both elevated. Is this surprising? Maybe not, because this patient has to be inflamed with these 6 months myopathies. So we'll look for an inflammatory process, and the inflammatory process are not many: autoimmune diseases, malignancies, infections for 6 months, maybe not likely. Malignancy will still sit there, and autoimmune diseases, I think, top of this disease. The other ones, yeah, so a CK is like a troponin to cardiac muscles. This patient has a muscle disease. Their muscles are inflamed, they're breaking down from anything, so they also release the CK. It also shows on that direction. LDH of 655. So also, what I think of LDH personally is, I say LDH, what it tells me is that there are cells bursting, cells of this patient are bursting out. For example, what you commonly know if you've rotated in or seen how these maybe hematologists or oncologists, though they do with the LDH, they suspect maybe lymphoma, and then they do LDH, because in lymphoma what happens, cells are being produced and dying very fast. So another way, if you have hemolysis, for example, your cells are bursting up, LDH is being released. So I think also, I don't know about in the muscle, but I will also take it in that direction, because if I start thinking in these other areas, I think it will be hard for me to explain. So I say this patient has hemolysis, but I know the HB is just 12, so that's not the case. I say the cells of this patient, the muscle cells are being eaten up, they're bursting up, so LDH is also being raised. Another labs, yeah. So that NA being positive, and down here, what I see as a positive there, Seba is telling us the JO1 MI2. So I start with the NA. So when an NA is positive, the next question is how positive is it? So I think sometimes, yes, we can do these qualitative ANA, which is positive, but what is more telling is if you have a quantitative, because as you know, from the Americans, what they are telling us with their literature is that 20% of their population has a positive ANA. Doesn't mean they have a disease. If this population is female, that goes up. But in elderly female like this patient, we don't expect ANA to be positive, because as you get old, everything gets old, including your immune system. So it's so less likely for it to mount stuff and start going how opposite of what it should be doing. So an ANA, a positive ANA in the elderly female, will take it more strongly. So when you have an ANA positive, in whatever disease that you have, you're thinking, you also do the subcategories for SLE, I think the dsDNA and the others that I'm seeing here, which are negative. So say maybe it is not SLE, but what you see is the anti-jaw. So I think the anti-jaw is the one for scleroderma. If I'm mistaken, Seba, you will correct me, but I think the anti-jaw is for scleroderma. Yeah, I think so, but I don't know if the MI2 was stand for. Yeah, I think it's for scleroderma because Sjogren is SSBSSA. So is this patient have Sjogren? I mean, our scleroderma. Not seeing anything that is telling me this patient have okay, maybe possible, maybe possible. Scleroderma with the myopathy, never seen before, because how it presents, yes, scleroderma can have a lung presentation, but to have a presentation in the muscles alone, maybe less likely, but is it possible these diseases are occurring in the same patient? And the answer is yes. Maybe the patient has a positive ANA, no subcategories for SLE, but there is for scleroderma. Patient doesn't have any other symptoms for scleroderma, but they have, we haven't have the imaging of the chest. Maybe they have an ILD. And what is that? So one thing maybe you can explain all of this. I think MCTD, a mixed connective tissue disorder. Maybe. Or another one that is also I also confuse with the mixed connective tissue disorder is the yes, it is a name, I think I will remember it later, but the mixed connective tissue disorder is it's a disease entity. It has an autoimmune marker. But if we don't have that autoimmune marker, you call it another name. I think I'll remember it. If anyone remembers it in the chat, they can share it. Yeah, overlap syndrome, I think that I was talking about overlap. So maybe overlap syndrome / mixed connective tissue disorder, that you have all these things. You have ILD, you have a positive ANA, you have anti-jaw, which is also positive, but you don't have the skin manifestation presentation of the scleroderma, and ANA is positive, but you don't have the presentation of SLE. Yeah, so I'll take that overlap syndrome and rest there. I think there are other labs, Seba. Yeah, okay, rheumatoid factor being negative. So rheumatoid factor is very important in this case, even if we are not being told that the patient have symmetrical small joint arthritis, because you can have a rheumatoid ILD without having the joint disease. So yeah, so that's important. Another one. Yeah, so the chart is telling me SCL 70 is for scleroderma, so which means that anti-jaw is the same as SSA, SSB maybe for Sjogren. If I'm also not doing that correct, you correct me in the chat. Thank you very much. So still says the same thing. Patient doesn't have what I think is a presentation for Sjogren Sika syndrome that I'm seeing here. So still the discussion will just change the name for scleroderma into Sjogren, but again, we don't see any things that are typical for that diseases. This slide, I think nothing important, Seba, unless there is. You remind me to discuss it. Okay, another slide. Yeah, so tumor markers, not for diagnosis, but if you see one which is high, you also maybe think of it, but there is nothing here. Next. Yeah, thyroid important because you can have endocrine disease like a hyperthyroid myopathy, which can present with the myopathy, but luckily the TSH is normal, so that's not the case. Yes, a D-dimer of 249 It needs explanation, but when you have a D-dimer, you increase your suspicion of PE. What it tells you is that do the CTPA, and in this patient, maybe we'll have, for me, I'll have to do a CTPA unless I have another answer for that shortness of breath. And nothing here, Seba, maybe. So does this mean about no RV dilatation?
Yes. So there was no any clinical significant RV dilatation, which was noted.
Okay.
Yes, even the mark of systolic function in the right side was also fairly preserved. The TAPSO, which was about 1.9 centimeter.
So there is no, the echo is normal, right?
Yes.
Okay. Yeah. So echo being normal tells us that we should put our focus on the DIB of this patient to the lungs, as we have done. We haven't talked anything about the cardiac. So yeah, the next I think is just a ECG. Yeah, so what I'm seeing here, it's just as it's just yeah, it's just a low voltage ECG, unless there's anything else. So a low voltage ECG, what it tells you is that the heart is too far away from your leads. Either there is anything in between there, fat for an obese patient, water for patient with a pericardial effusion, or pleural effusion, or pneumothorax. Otherwise, we we haven't been told of any other complaint of this. You think of water, especially if there is what is called an electric alternance, that there are small, but you see that the amplitude changes from one wave to another, which I'm not appreciating it. But if it was there again, we would have seen it on the echo. So I would think maybe it's more like to be fat. Next, Seba.
Maybe I can play the video, Dr. Joseph, if you can
Sure,
appreciate something. If not, then
sure.
I will report the findings to you.
Um,
Anything, Dr. Joseph?
I'm not seeing anything. You have to tell me.
So there was a filling defect that was predominantly found in the right pulmonary artery, so in the lobe and the segmental branches.
Okay, so that is a PE, right?
Yes, yes.
Okay, thank you. Yeah, so this is what we have. First of all, thank you very much. I think this Jonavia Anton. Thank you very much. So I was getting it wrong. The anti-Jo and anti-MI2 for polymyositis. Okay, thank you very much. I will take that. So it's not the scleroderma sjogren's that I was talking about. I was mixing up things. Thank you. So it's a polymyositis, which we knew that is polymyositis even before we had these markers. But thank you for that, and that's a learning for everyone else. So yeah, we have a PE. We were suspecting that this patient might be having a PE, and now we have a PE. Now, should we connect this PE? But first of all, this is the patient who has PE through, and he has rivaroxaban. Unless this patient is not using well the rivaroxaban, I have to say antiphospholipid syndrome, unless proven otherwise. This is the patient you have to take the lab and send for the 2 or 3 autoantibodies for antiphospholipid syndrome. Because otherwise, if you leave them, You have to explain why do they have a PE through rivaroxaban? Why are they clotting? Which means you have to change the to warfarin. But is it related to is it related to what we are seeing as a polymyositis? And one aspect that I said is that unless the PE is part of an ongoing malignancy, it's an hypercoagulable state, and the polymyositis is also part of that malignancy is an paraneoplastic syndrome. But we've done imaging of the chest, and maybe in the chest there is no malignancy. Should we also scan the patient? I'll need to do that for me. Is this patient also do chest, abdominal, pelvis to see? Being old also means you've lived longer, you collect enough risk factors for getting any cancer at that age. Or are these standalone diseases? The patient have polymyositis, common, maybe one side, and then they're just clotting, which is something else, and they had what is called asthma now, what is called asthma for long time that is being treated, and the dry cough, and which is not responding nowadays to inhalers. Maybe the an ILD that is an autoimmune. That category of diseases are very hard for me, I can tell you, because now I have to recall other markers that you should send, and I don't remember any. So I'll be there, Seba. It's so hard to say if all these three things are connected, but if they are connected, I'll look for a cancer. If they are not connected, at least I can connect the autoimmune polymyositis plus ILD. We are not seeing ILD in this CT here because it's not the choice for CT to see an ILD will be a CT with I think it's called an HRCT that has small slices that will tell us issues. So patient will have a lot of imaging, I think, and yeah, that can be connected with a polymyositis. Standalone PE, clotting through rivaroxaban. I would need to send tests for antiphospholipid syndrome, Seba. Is this the end, or we have anything else?
I think this is the end, Dr. Joseph.
Yeah. So
maybe before you commit, an extra search for occult malignance was done in this 72 years old female. Okay. So there was not any evidence of any occult malignance by the abdominal pelvic CT scan was normal, and even the chest X-ray, there was not any suspicious nodule which could pinpoint us into thinking of a possibility of lung malignance.
And did you guys maybe manage to do a HRCT, or it was too much for the patient?
Yeah, so HRCT at this point in time was not done. Okay. Maybe with subsequent visit we can think of doing that.
Yeah, sure.
Yes.
Yeah. So if there is no malignancy, then I'll be asking, how should I connect a PE with the polymyositis? And I can't do that for you. I'll have to keep them apart. But the lung disease with the polymyositis, maybe, because they are all autoimmune if I have an HRCT. Yeah, so that's it.
Thank you, Dr. Joseph. I think that is an excellent clinical approach. So this is the patients that we ourselves, we really scratched our heads onto thinking, can we connect pulmonary embolism and with idiopathic inflammatory myopathy, most likely polymyositis in these patients? So thinking of this, we went ahead, then we dug some literatures to see if there is any proven association between pulmonary embolism and inflammatory myopathy. So surprising enough, we found some cases which were very close to our case, which explained that patients with inflammatory myopathy are at risk of getting arterial and venous thromboembolism. So maybe we have some teaching points ahead. So then we couldn't rule out an phospholipid syndrome, as you have correctly said, Dr. Joseph, in these patients. Patients having pulmonary embolism on consistently and very adherence to rivaroxaban and, and phospholipid syndrome has to be one of the top things, differentials to think about. There was another important part that we also thought to these patients. There is a specific syndrome that we came across, which is known as unsynthetase syndrome, which presents with myopathy, specifically same picture as idiopathic inflammatory myopathy like polymyositis, together with the presence of interstitial lung disease. And these are the patients that also tends to have the positive, there is one which you've seen, the Jo1. So Jo1 antibody has been associated with the unsynthetase syndrome. So we thought there is a possibility, very high possibility of overlap in these patients. So until now, we can't rule out possibility of overlap syndrome in this patient. So up to the final moment, we are working our patient as idiopathic inflammatory myopathy, more likely polymyositis, presenting with pulmonary embolism, with a high possibility of unphospholipid syndrome. So we at this point in time, we couldn't do the unphospholipid antibodies, the anticardiolipin, the lupus and anticoagulants. So these were some few teaching points. So inflammatory myositis commonly refers to three groups of diseases, which is polymyositis, dermatomyositis, then we also have the inclusion body myositis. So these are the systemic autoimmune diseases that are characterized by chronic muscle weakness. They're usually associated with an activation of the inflammatory response with cellular infiltrate in the skeletal muscles. So they're fairly rare diseases, and they're more common in women, especially from the fifth and sixth decade of life. So a striking point that we came across is that inflammatory myopathies carry an increased risk of arterial thrombosis and venous thrombosis. So the arterial thrombosis, which is the ischemic heart disease and the cerebrovascular events, together with the venous thrombosis, which is VTE, with subsequent pulmonary embolism. So this is what I've said. With the presence of multiple autoimmune antibodies, which was the presence of ANA positivity, presence of M12, which almost always defines presence of an inflammatory myopathy, whether dermatomyositis or polymyositis, suggests that there is a strong autoimmune process going on and the possibility of overlap. So an important point to stress on today's AfroDX, I think, is this point that autoimmune diseases should be considered to have a recognized risk of an increased arterial and venous thrombosis. Then recurrent pulmonary embolism, despite being on rivaroxaban, as Dr. Joseph, you have strongly highlighted, and phospholipid syndrome cannot be ruled out. So these are multiple postulated theories on why patients with autoimmune disease may end up having an arterial or venous thrombosis. So the most important thing is usually endothelial dysfunction, which is mediated by cytokine-mediated injuries, specifically highly inflammatory cytokines, which is the interleukin-6, interleukin-1, and the tumor necrosis factor alpha. There is also an upregulation of the procoagulants pathways due to the fact that there is more tissue expression from the activated monocytes. And there is also a downplay of the natural anticoagulants, the protein C in patients who are having autoimmune diseases. There is also a heightened extent of platelet activation and aggregation. So all of these subsequently help in contributing into an hypercoagulable state in patients who are having an autoimmune disease, speaking in this context for inflammatory idiopathic myopathies. So the question that we went ahead and asked yourself, now, do all patients who are having autoimmune condition, should they need a venous thromboembolism prophylaxis? So this has to be considered maybe when you are having hospitalized patient with autoimmune that are non-ambulant completely. They cannot perform even some sort of bedside ambulation. very sick patients, no any way they can perform bedside ambulation, then anticoagulation may be considered in these patients. When you are having a definitive, clearly defined thrombotic and phospholipid syndrome, these are the patients that straightforward should be kept on warfarin, because rivaroxaban has been shown to be not very efficacious in patients who are having APS. And also something which we have also come across is patients who are having an active inflammatory bowel disease. So patients who are having ulcerative colitis, Crohn's disease, and even microscopic colitis. So we have ever come across a case of a patient with microscopic colitis who ended up developing a venous thromboembolism. So there is a clearly associated causal. I'm not sure if it's if I should use the term causal relationship. Maybe for the meantime I can use that, between an active inflammatory bowel disease flare with the development of a subsequent venous thromboembolism. So this is just a practical summary on how to approach VTE with respect to different diagnostic conditions. So when you're having an phospholipid syndrome with either arterial thrombosis or venous thrombosis, then the novel anticoagulants like the warfarin, the bigatran, they're out of use in this particular patient. So warfarin is the drug of choice due to the fact that it counteracts the coagulation cascade at different numbers of the clotting factors, as opposing to rivaroxaban, which is, if you use an example of rivaroxaban, which targets only a single factor, which is factor 10. So when you're having a patient with recurrent thrombosis on rivaroxaban or dabigatran, always think of antiphospholipid syndrome and consider switching the patients to warfarin. Then autoimmune disease without antiphospholipid syndrome, if you've done some antiphospholipid syndrome markers, then there is no any evidence of APS, then a DOAC may be acceptable in these patients. Then there is also pregnancy with antiphospholipid syndrome due to the teratogenicity of warfarin, especially when you go above the dose of 5 milligram per day. Then and low molecular weight has to be used in these particular patients. Yes, I think this was today's discussion. Welcome, Dr. Joseph.
Seba, thank you very much. This is a wonderful case. A lot of learning, but much have been discussed. One thing that there are students here and other learners. I say one thing. You've seen, I have discussed this patient, and then I didn't know to interpret the subcategories of ANA. And how do you come to know that? It's when you do something like this. Because I just sitting, I know ANA, I know SSB, SSA, anti-Jo, but turns out you've forgotten, and that's totally okay. But how do you know that has happened? And until you do something active like this, and someone comes in there, reminds you, okay, doc, you have been wrong. This has to be this. That learning will stick forever. Like for now, I think this will stick forever for me. So Seba, thank you very much. It's a tough case and very good teaching points. Yeah. Do you have anything else from anyone?
Yeah, do you see any hands, Joseph? I can't see any. Uh, Jonaviva Anthony was very active today. Seems this is one of your strong areas. Some very good contributions there, especially with regards to the autoimmune markers. Do you have anything that you'd like to share with us by speaking, if anything, and if there is anyone else who has any questions, comments, contributions, or any experience to share, you can just unmute and speak.
Yes, hello everyone.
Yes, hello. Please welcome. And Unaviva, I see no problem. Thank you very much for the contributions in the chat. Caesar, please welcome.
Okay, thank you so much, Dr. David and Dr. Joseph, as well as Dr. Sebastian. It was one of the very interesting cases. I actually lost up as one among the followers because I didn't get any connection between the weaknesses of the patient and difficulty in breathing. And I was struggling to connect the two pathologies. I always do believe God is so merciful to give a person two different type of disease at the same time. Normally, there's a connection somewhere. But I thank you so much, Dr. Sebastian, for the link you showed for us. But my one insight was, if I recall back, most of these APSs for women, they always have some sort of obstetric history. For adult women around 72 years of age, was it not important to, if we ascertain maybe this some sort of APSs because of the recurrent pulmonary embolism, despite the fact of being on anticoagulant, was it not necessary for us to even have some sort of retrospective history of our obstetric background? Because at some point in time, these, if I remember well, they could have some sort of bad obstetric history, whether some sort of miscarriages, some sort of certain gestational ages, which at some point in time will argument our standing if our thinking is right, if this is a EPS. But all in all, thank you so much for a very interesting case.
Thank you, Caesar, for the good observations. Joseph and Seba, if you have anything in response.
Thank you, Dr. Cizo, for your very good observation. Yes, I quite agree with you that one of the most common presenting ways of females, specifically those of pregnant bearing age, is usually infertility. APS is usually one of the most common causes of infertility. I think it accounts for almost up to 10% of infertilities may be attributed to APS. But with this 72 years old female at this particular point in time and the retrospective history, the obstetric, specifically for the obstetric history, she was a successful mother. She had almost, I think it's five children. So during her time when she was in her reproductive age, she did not have any challenges regarding to infertility. So, and also absence of infertility does not strictly rule out a possibility of APS, especially in this old 72 years old female.
Okay, thank you.
Thank you. I do not see any other hands. So Seba, you have another case for Joseph, right?
As for next week,
Yes, for next week.
yes, I think we'll find another case.
Oh yes, oh yeah. I hope Joseph will have some fun. It's been a while. He has not been discussing many times. So yeah, Joseph will discuss another case next week. I hope people enjoyed. So I was here learning a lot of things. So thank you very much, Seba, for preparing the case very well detailed, and Joseph for the education that you gave us today. Yeah, remind us again if you have cases, please feel free to share, and if you want to discuss, just reach out and be part of the discussants. Otherwise, have a good night, everyone, and see you next week, and see you on Sunday. Bye.
Good night.